Good evening to one and all present here. We will be
Recording in
start,
progress.
we will be starting off with the webinar shortly. Till others are joining in, we will be presenting some glimpse of our past departmental events and activities. Before commencing with the session, I would like to lay down some general instructions for the attendees present here. All the attendees are requested to join through either PC or laptop for a better visual experience. Panelists are required to keep their videos on for a better visual experience. Questions may be posted over the Q&A box and all the queries will be answered at the end of the session.
Recording stopped.
We will begin in few minutes. We are waiting for our chief guest to join in.
Before commencing with the session, I would like to lay down some general instructions for the attendees and panelists present here. All the attendees are requested to join through either PC or laptop for a better visual experience. Panelists are requested to keep their videos on for a better visual experience. Questions may be posted over the Q&A box, and all the queries will be answered at the end of the session. Thank you.
I think we can begin now. We can begin now. We have our guests are all there, have joined.
That's me.
On behalf,
Let me know if is the connection fine?
Yes, ma'am.
Okay.
Absolutely.
Sorry, I'm using my son's computer, So there are always risks with using a little boy's computer.
No problem. Yes, anchors.
On behalf of the Center for Multidisciplinary Research, Innovation and Entrepreneurship, under the aegis of Shahid Rajguru College, University of Delhi, Internal Quality Assurance Cell, IQAC, and Department of Management Studies, I, Shruti Agarwal, along with Hema, Anjali, and Sunishtha, feel extremely honored to extend a very warm welcome to our Honorable Chief Guest, Professor Shamika Ravi, non-resident senior fellow, Dr. Abhishek Tandon, former Deputy Director Research, ICSSR, esteemed Principal Ma'am, Dr. Payal Mago, and Associate Professor of Food Technology Department, Dr. Ranjana Singh. We welcome you all. I would also like to extend our sincere and heartfelt welcome to all the scholarly and knowledgeable professors, thoughtful audience present here. We are glad to have you all join us to the expert session on COVID pandemic and use of blockchain technologies in building health, insurance, and financial chains to meet the challenge.
Recording in progress.
Thank you all for joining in. A special mention to our knowledge partner, ICSSR, Indian Council of Social Science Research. ICSSR, established in the year of 1969 by the Government of India, aims to promote and proliferate research in social sciences in the country through grants, fellowships, scholarships, and financial assistance. It advises the Government of India on all matters pertaining to social science research. We are truly humbled beyond measure for such an overwhelming response. We assure that you will certainly have some valuable takeaways from this session, and we hope that this webinar serves you just the right way to know about blockchains in many depths and areas of expertise.
It is our holy tradition to worship our gods before any important event. So we dedicate our prayers to invoke the blessings of Almighty. Lights as a symbol of brightness, and knowledge excels ignorance and darkness and brings prosperity to our lives. That was indeed a beautiful start to a holistic and enriching session, which lies ahead for all of us. With the blessings of Almighty, let us now commence with today's session.
Shahid Rajguru College, affiliated to University of Delhi, was established in the year 1989. The college offers 14 courses in various disciplines such as sciences, management, and finance. We were recently accredited with A+ grade by the National Assessment and Accreditation Council and ranked 37 by National Institution Ranking Framework. The college has always aimed to focus on holistic development of students by providing students a plethora of opportunities to develop their interests, aptitude, and helping them in enhancing their overall personality. The Department of Management Studies and the Department of Financial Studies came into being by 2017. The department has organized multiple sessions with eminent speakers such as former Chief Economic Advisor Dr. Krishnamurthy Subramanian, Mr. Sanjeev Sanyal, and Mr. Ram Gopal Agarwala, to name a few. In the cultural events, the department organized its Technical Fest Idaira and has invited famous stand-up comic artists such as Harsh Gujral and Akash Gupta. Moreover, the department had successfully organized the International Young Researchers Conclave in 2020, where 48 participants from various nationalities participated. Now, I would like to invite Professor Dr. Payal Mago, who is the pride of our college, and we are all honored to have her as our principal. Ma'am is the Director of Campus for Open Learning and former Joint Dean of Academic Affairs and Project, University of Delhi. Ma'am is also the founding member of Society for Professional and Academic Excellence. Ma'am has around 25 years of teaching and administrative experience in the field of education planning. Ma'am has been awarded a Lifetime Achievement Award by Women's Agency for Generating Employment. Ma'am has been extremely supportive and encouraging and has always guided the students and made them strive for the best. Ma'am, I would like to request you for the welcome address of our honorable chief guest and mark the beginning of the event.
Good afternoon, everyone. On behalf of Center for Multidisciplinary Research and Innovation and Entrepreneurship under the aegis of Shahid Rajguru College, I extend heartiest welcome to Professor Shamika Ravi. It is indeed our honor to have you here in our college. You'll be speaking on the blockchains, which is actually very important for all our students, and especially our management and finance students who have joined today and taken an initiative to call you. I welcome you, ma'am, and I also welcome all the participants who have joined and all the panelists who have joined this program. And sometimes I thank the lockdown that because of it, although we faced real trouble during this time, but knowledge is flowing from all directions in the form of webinars, in the form of communications from different areas. So the best part with the human beings is they never stop. They never stop their progress. So that is the positive part of what we are going through, because we have to live whatever way we are living, we have to think positively. So once again, I welcome Professor Shamika Ravi to this program, and all the panelists and all the participants who have joined. And I hope this program is going to be, this talk is going to be very, very useful and eye-opener for all of us. Thank you so much.
Thank you, ma'am. We are privileged to have you amongst us as our mentor. Now, I would like to invite Dr. Ranjana Singh to introduce Center for Multidisciplinary Research, Innovation and Entrepreneurship to our audience. Ranjana ma'am is working as Associate Professor of Food Technology and has more than 10 years of teaching experience. Ma'am is the coordinator for Center for Multidisciplinary Research, Innovation and Entrepreneurship. Ma'am also helped in establishing the Entrepreneurship Development Cell and Institution Innovation Council in our college, which mainly focuses on innovation and startup. Ma'am has also done many researches which are published in international journals. We welcome you, ma'am.
Thank you. Would you please project my slide? Would you please project my PPT?
Sure, ma'am.
Thank you. Good afternoon, everyone. Honorable guest of the day, Professor Shamika Ravi, VP Observer Research Foundation and Non-Resident Senior Fellow, Principal Dr. Payal Mago, Deputy Director ICSSR Dr. Abhishek Tandon, faculty members and students. I take this moment to thank our Principal Dr. Mago to provide me this opportunity to present about the Center for Multidisciplinary Research, Innovation and Entrepreneurship. The next slide, please. The Center for Multidisciplinary Research, Innovation and Entrepreneurship is the umbrella body for nurturing and overseeing research-based innovations and entrepreneurship at this institute. It is a pedestal to help knowledge-driven enterprises to establish and prosper under organized scientific guidance. The center harbors the multidisciplinary research, innovation, and entrepreneurship under one roof for better coordination and end results. The institute is embedded with adequate and latest infrastructure and provides the necessary mentorship to form a multidisciplinary research, pre-incubation, and entrepreneurship program. The center aims for an overall growth and development of women and encourages them to start their own research or business idea enterprise. Center is set up to support social entrepreneurship and women startup endeavors. Next slide, please. There are various programs running under the Center of Multidisciplinary Research, Innovation and Entrepreneurship. And the first one is research-based projects, workshops and internship. Incorporating a research component along with a strong academic foundation enables students to develop independent critical thinking and communication skills. Keeping this in mind, various departments of our institute have been running major and minor research projects funded by University of Delhi, Department of Science and Technology, DBT, ICSSR, and Cisco. Various interdepartmental minor projects have been planned to support experiential learning. The internships are an important part of degree program, which adds a lot of practical knowledge and confidence among the students. Research papers have been published in reputed journals and patents are being filed. The second one is the Entrepreneurship Development Cell. The ED cell conducts various awareness programs such as seminars, workshops, fest, and interaction with successful entrepreneurs. These programs are done with the vision to produce successful entrepreneurs imbibed with innovative skills and ethical business practices, contributing to the development of society and growth of nation. The next slide, please. Another program running under the center is Institution Innovation Council, and the major activities which are conducted under Institution Innovation Council are various innovation and entrepreneurship based programs as per the calendar activities of MIC, then the identifying and awarding innovation and sharing success stories, creation of e-clinic by the innovation ambassador for the entrepreneurial support to students within and outside the college, and organizing hackathon, idea competition, participation in National Innovation Challenge. The next program running under the center is Technology Business Incubator. And under this TBI, Institute has conducted business plan competition thrice, once at college level, once at state level, and once at national level. The best ideas were shortlisted to be nurtured under the TBI with the assistance of MSME. Another program which is under process is Rajguru Innovation and Startup Policy. This is being drafted as per the NISP 2019, and the center is under process of formulating its own policy, which is entitled Rajguru Innovation and Startup Policy, which would be as per the convenience, as per the program for the students as well as faculty. Please, next slide, please. Yeah, another program which is being conducted under the center is Enactus. Enactus of our institute is working under the center with the goal of making positive influence on community. Enactus believes in identifying possibilities, transforming into tangible, sustainable projects, and uplifting the underprivileged section of society. It also at the same time sensitizes young students to be responsible for their society and their needs. There are various projects which are being conducted under Enactus. To name a few, the first one was Project Pehchan, which was aimed to transform the lives of LGBTQIA+ community and to ensure their sustainable growth through imparting them skill development in various areas, followed by opportunities of employment. This Project Pehchan has had two sub-projects under it. The first one was Sehaj, where skills of food processing were imparted, and in the second one, Kashida, the skills of stitching of clothes and marketing was imparted to them. Next slide, please. There is one more type of entrepreneurship, which is social entrepreneurship, which is being conducted under the center. And there are two projects which are taken up. The first one is pertaining to mushroom cultivation, which empowers students with the knowledge of commercial scale mushroom cultivation. It also supports the opportunity of startup and employment and opens up research opportunities with respect to converting mushroom into value-added products, as well as isolating the compounds having medicinal value. The second project, which is done under social entrepreneurship, is related to composting, which is an initiative to recycle green and wet waste of the premises, and at the same time sensitizing students towards conservation of environment. I would conclude here by saying that the Center for Multidisciplinary Research, Innovation and Entrepreneurship has been running successfully, coordinating all the programs for their best and efficient outputs. Thank you. And over to Hema.
Thank you so much, Ranjana ma'am, for enlightening us with better insights into Center for Multidisciplinary Research, Innovation and Entrepreneurship. I'm sure everyone is excited for this new addition to our institute. As the pandemic hit the worldwide economy, every single arena in the world went for a toss. Consumer demand, supply flipped the economy and came to a standstill. But even during such adverse times, the only field that prospered was that of technology. One such technological aspect is blockchain. Blockchain is a system of recording information in a way that makes it difficult or possible to change, hack, or cheat the system. This technology, introduced in 1991, eventually gained importance in 2008. It has been massively useful tool in the areas of health, insurance, and financial chains. Blockchain has a very strong precise and systematic way of recording transactions accurately, which makes it very easy to track users. Blockchain also helped in recovering the economy. Blockchain technology is one of the leading innovations in the finance industries, holding promise to reduce fraud, insurance, quick and secure transactions and trades, and ultimately help manage risk. But to its efficiency, today blockchain is being used in various arenas such as NFT, marketplaces, tracking, personal identity security, and cross-border payments.
To explain and enlighten more on the topic, COVID pandemic and use of blockchain technologies in building health, insurance, and financial chains to meet the challenge. We are very fortunate and honored to have with us non-resident senior fellow, Brookings Institution, Washington, D.C., Vice President, Observer Research Foundation, Professor Shamika Ravi. Ma'am was the former Director of Research at Brookings, India. Ma'am is a visiting professor of economics at the BITS School of Management and the Indian School of Business. Ma'am was also a member of Economic Advisory Council to the Prime Minister of India. Ma'am publishes extensively in peer-reviewed academic journals and writes regular opinion pieces in major newspapers. The research work of Professor Shamika has been featured and frequently cited by leading global media outlets, as well as national and regional newspapers and magazines across India in different languages. We all together truly express our heartfelt gratitude for accepting our invitation to address the students. We are truly honored to welcome our profound chief guest for the evening, Professor Shamika Ravi. We welcome you, ma'am.
Thank you, Shruti. Namaskar, everyone. First of all, my gratitude to Principal Professor Mago, Dr. Ranjana Singh, and of course the guest today, Dr. Abhishek as well. Most of all, my dear students, it's always a privilege and it's a rare honor, I must say, to meet such a large group of women students. I've always, and you know, I've been teaching for 20 years, and I try to very consciously keep and focus my research, though it is not on gender specifically, because there is nothing very peculiar about the problems we face, and yet a lot of the problems that our women business leaders and entrepreneurs face are quite universal and across different areas of business. So I've been teaching in MBA programs and business schools now for almost 20 years. And sometimes my male students often jokingly say that, you know, you always have a soft corner for the women in the class. You give them a chance to speak more. And that's the whole idea, that platforms like these and institutions, I mean, I'm so glad that Shahid Rajguru College of Applied Sciences for Women has come a long way in innovation. It's wonderful to see the center, Center for Multidisciplinary Research, Innovation and Entrepreneurship. We keep talking about multidisciplinary research because we know that the problems of the world cannot be solved by specialists who have a very limited view of the problem in the world. So we do need multidisciplinary approach, whether it is to our policy problems, so problems of governance, or it's problems of business. We do need to have a multidisciplinary approach. So it's fascinating to see the kind of courses, etc., that are being offered at the center. Most of all, of course, thank you very much for this opportunity. I have prepared a slide more as a teaching tool.
Recording in progress.
I have labeled it, it's of course blockchain. I'm going to keep talking about blockchain throughout this talk, this lecture. But broadly, it is about the pandemic, public health, and technology, and why the pandemic has escalated in many ways the transition which we were already seeing in the economy over the last several years, not just in India, but in many of global economies. Now, this is just to give you a sense of, for a resource poor economy, and I want to underscore that, because when you read newspaper articles, when you watch your television sets, most experts, when they talk about Indian policy making, particularly in the backdrop of the pandemic, we compare ourselves with very rich OECD countries. We want to emulate and copy the policies of these affluent countries. And yet the reality is that we are a resource poor country. We are a country which has systematically underinvested in a lot of very critical sectors of human capital, such as health and education. And most of you, you are from a background as similar to mine. We grew up in India, we know the society at large. When people talk of social sector, it is seemingly less important and exciting as, let's say, mainstream finance. And it is the same case, or marketing for that matter. It is exactly the same approach and biases that enters the government system as well. That health, education, gender, these are seen as, these are not the key portfolios or the most important parts of government. And yet, these are the core of what is called human capital. A country is really grown on the backdrop of its people. Healthy, educated, skilled manpower makes a country prosper, grow. So growth is very much dependent on the population. So disregarding human capital will naturally come at its own peril. And so in many ways, the escalated effort, of course, there have been lots of comprehensive policy reforms as far as healthcare and education sector were concerned, but the pandemic has put that squarely in the middle of, it has forced it to become a priority today. I want to start by telling you that despite being resource poor, we were able to, the vaccination drive in the country has surprised many. That how quickly a country like India, with its limited resources, and we must be honest, not every part of the country also has the governance capacity. Many states struggle when it comes to public health infrastructure and state capacity to administer such a large number of vaccinations in real time. And yet, look how quickly sometimes even poor states, and Madhya Pradesh really stands out, that it's not always the rich states that are doing well. Some of our most backward states have also performed very well. And that is, of course, a large part has to do with priority and clear policy making and driven from the top. But technology is a very large part of it. States which are adopting and adapting a lot of the new technology are able to meet a lot of their targets in a real time. This is where we are today. Again, a resource poor country with this kind of backdrop. We have states like Himachal, we have states like Madhya Pradesh. These have crossed more than 80% full vaccination of eligible population, and eligible here is more than 15 years. Okay, so you have to appreciate the fact that from where we have come to where what we have achieved in this duration of time is quite remarkable. Almost 61% of eligible Indians, meaning age 15 and above, are today fully vaccinated. This is no mean feat. This has technology is a great enabler in this particular episode. Now, when we talk of blockchain, when we talk of any technology, at the back of a lot of this is the current existing data systems that we have. So, for instance, in healthcare, because that is the area of interest for you today, globally, new AI, artificial intelligence solutions, machine learning solutions are being deployed in hospital systems, in public health systems to improve quality of care. Now, machine learning, artificial intelligence, these are tools that fundamentally depend on the quality of the data. So if you're able to come up with good data systems and we have systematic data collection, it is easier to deploy these wonderful mechanisms of making things more efficient and cheaper. Now in India, we have a very acute shortage of doctors and nurses, ANMs, etc. And one of the solutions to having this kind of supply constraint is deploying technology. So we have had successful cases of primary health centers in UP around Lucknow getting wired to doctors in Andhra Pradesh. So it's part of telemedicine. It has been successfully experimented. We have had some very successful experiments happen in Tripura, and so the northeastern part of the country, where these medical facilities are linked with doctors in Delhi and Jaipur, etc. So important to know that experiments are happening in the industry, on the field. But fundamentally, a lot of it depends on the quality of our data and what are the products we can develop from it. Now, in the most recent past, there's been a lot of debate on deaths. And one fallacy, and I think the reason I call it a fallacy, is that there is no grand scheme to hide numbers in terms of deaths. If people appreciate, and you must, as Indians who are part of the system, you are going to be the key drivers of this in the future. In India, we don't record every birth and every death, okay, till today. So we really, even under normal circumstances, we don't have a count of actually how many people died. Now, to those of you from statistics background, you know what estimates are. So in India, deaths have always been estimated based on surveys. Annually, we do a survey, and it's a representative survey. So we say, we estimate X number of deaths in India over the last 1 year. So against that backdrop, that we don't have a civil registration of vital statistics, where we are counting every birth, every death. And of course, like in Scandinavian countries, you can measure who migrates from where, what is the marriage status, etc., etc. So civil registration of vital statistics is an area towards which we are moving, and Aadhaar is making all of that relatively more feasible, but we are still far away from that. Because to have good data also means you need foot soldiers, you need people on the ground who can actually enter this data, right? Now this graph, the reason I show you this is that red graph on top is telling you what are the estimated number of deaths, and you see that it is relatively flat, because given the population, you're not going to see big changes in number of deaths from year to year. The blue line below is telling you how many registered deaths are happening in India. Now clearly registered deaths are shooting up. This is clearly before pandemic. So if you use very simple logic, even by simple metric like this, you will say even before the pandemic, India had more than 1 lakh excess deaths in 2019-20. That is of course a problem, because registrations are rising, not the actual deaths. We are registering more and more death. Our data systems are getting digitized and so on and so forth. So against this reality, it is important to understand that this happens through multiple channels. It's a very large country, and the collection of data happens at highly localized level, and then it gets aggregated and so on and so forth. So now there are states, for instance, where, for instance, Delhi traditionally reports around 250% more death than actual number of death. So if the estimated death in Delhi is 100, registered deaths will be 250. Why is that? Because many people from the neighborhood come to Delhi for healthcare, and unfortunately many will die. So places, big cities, places that have good health infrastructure also have many much higher registered deaths, multiple of what their actual numbers are. Now this is like looking for the needle where the light falls. So during the pandemic, the great anxiety that has developed, of course there have been deaths, there have been a very large number of deaths, right? We have all lost people, we know that. But sensationalizing it in this kind of an architecture, because we don't have real-time data collection. If we only look at Delhi, we'll say they could 250% deaths have happened compared to actual deaths. But that is a usual system. All right. Now this is systematic. Again, statistically, these are systematic bias. It's not random. States like Andhra, Gujarat, look at Kerala. These are states that have traditionally reported much higher than 100%. Chandigarh reports 400% more deaths than estimated deaths, because Chandigarh is a hub of healthcare in all of this northern belt. All right. Similarly, then look at Madhya Pradesh, look at Rajasthan, look at West Bengal, look at Uttar Pradesh, Bihar. We have registered hardly 60 to 70% of total deaths in those places, even under normal circumstances. So our data systems, we're trying to use a technology to improve the systems, and eventually I'm getting to electronic health record, which is at the heart of this blockchain transformation. But appreciate the fact that technology is not a panacea. There's no silver bullet. At the end of it, actual service has to happen, actual digitization has to happen. Somebody has to enter this data, right? Every transaction, blockchain is a distributed technology where every transaction is entered and retained. So you keep this, electronic ledgers, so-called. But entering the data, there's a huge gap on the ground we have, and this is a systematic gap. Now, another thing, and it's important for the girls, you guys to know, there's a systematic gender bias as well. All right, not just in terms of deaths. Of course, death registration, you look at it, there are over 100 districts in the country which have reported single digit or double, 2, 20, 30 deaths in the whole year of women and children. Now, why is that? Why is there a systematic? Technology is also systematically biased against vulnerable segments in the society. Typically, registration data is recorded for transactions where there is an economic repercussion. So property exchange, there are some legal implications of it. Women and children, mostly babies under 5, there are no economic implications of that death. So very few children are getting registered in our, in our data registrations. But as a citizen, they are citizens of India. We better count them. That's why we count infant mortality. That's why we count neonatal, that how many are born and how many die and so on. But the gender gap is very real. Even in terms of an otherwise successful vaccination drive, look at these graphs. These big yellow areas are showing what is the real gender gap in the vaccination drive across states. Other than Chhattisgarh, Himachal Pradesh, and Andhra Pradesh, every other state is reporting very large gender gap in vaccination. Now, clearly, it is not a policy issue, right? Because the government has made it available to everyone above 15 now. A lot of the problems in the gap are very much societal. And so having a uniform solution to a lot of these problems are not going to erase what is a systematic bias in the society. In fact, we have a British Medical Journal article which came out 4 or 5 years back, where I published a paper together with the director of AIIMS, Dr. Randeep Guleria, where we estimate, if you look at the AIIMS data, that nearly 50% of female patients are missing. Meaning, if people got women to hospital as likely as men, we would have had 50% more women. Right? So the study is disregarding obstetrics and gynecology, the departments where women go. But, when it comes to knees, when it comes to, accidents, injuries, when it comes to heart ailments, when it comes to lung ailments, systematically women are underrepresented, meaning women are not brought to the hospital. So there is a bias in the system, and the data that generates that we have or we have digitized is systematically going to underrepresent. So the solutions that we have are therefore also going to be biased, because we have to go beyond technology. Now we really have to, at least as far as vaccination drive is concerned, we'll have to do something beyond what we are doing to get all women to get vaccinated. Why is this a problem? Because it's an infectious disease. Corona is highly infectious. So having individuals, women who are unvaccinated in the household or the colony or the society means that negative externalities are still very much there. We have people who are vulnerable and they are going to spread and so on and so forth. So it's not just for the sake of women, but society at large also. But this is an important metric. It tells you how biased even vaccination is. Having said that, economic recovery in India has been, barring the first quarter, we have seen rapid recovery since. What you see is the big decline in economic activity as of March, when we went into a lockdown, when Corona broke out. And then we grew very slowly, but it was a very steady growth. And then you see again a huge decline that happened in the second wave. And again, you are seeing every state, I have represented very few here, and this data is of October. As of now, every state of the country is above pre-pandemic level. But this is economic recovery in terms of mobility, sales, etc. Consumption is still below. This is now to sensitize you to the fact that we have huge rural-urban gap. Okay, these are two graphs. Each dot in this graph indicates 1,000 households. A green dot represents 1,000 rich households, wealthy households. A yellow dot indicates 1,000 middle-class household, and red dot indicates 1,000 poor households. These are by wealth category, not income. So actual asset ownership and so on and so forth. First of all, when you look at these two, do you see that there is a difference? There is, urban India is far richer than rural India. Okay. In fact, if you look at the left panel, you can identify the cities of India. The clusters of wealth that you have in the country are our cities. That is why we say cities are engines of growth. A lot of the technology solutions, a lot of what is happening, even in terms of the pandemic and the way we have responded, it's very much concentrated on the cities. Rural India has a very large concentration of poverty, as you are seeing in the right side panel. Huge disparities, okay? Now, let me get to, because you're all students of business, and it's important, you are students of science and applied sciences, but with interest in entrepreneurship and innovation, etc. It's important for you to understand that insurance, while we have one of the world's largest cardiovascular ailments, etc., the countries are very similar in health outcomes. Okay, and yet US spends 18% of its GDP on healthcare. And can anyone guess how much Singapore spends on healthcare? Well, it's 4%. So you see, with very similar outcomes, you have two countries having very different financing methods of healthcare. The US is spending 18%. US is the largest economy in the world, having spent largest segment is going into healthcare, 18%. And it has the same health outcomes as Singapore, which is 4%. The difference is quite stark because in the US, financing is primarily on the back of insurance, right? It's private health insurance driven financing of healthcare, while Singapore does not depend on insurance. Singapore has what we call more of health savings. So there is a pot of money given to every household, and that pot is meant to be used for specific things like housing and health, right? Now, there are concepts of adverse selection and moral hazard that all of you should be familiar with. These are core concepts of information asymmetry of economics. In fact, Nobel Prize was given for the not just discovery, but detailing of these concepts, why markets break down. One of the reasons why markets break down, and insurance market often breaks down, is because there is something called adverse selection, that if you leave it to people by themselves to come and buy insurance, only those who are truly sick and who are in need of it will come and buy it. All right, which makes the market very difficult to price, which is why most countries that depend on health insurance don't leave it to people's judgment. They make it mandatory. If it's an insurance finance system, you have to buy insurance. And that is the system of the US, for instance. Right? Now, the second problem why markets break down or have very difficult time pricing in insurance is what is called moral hazard. That people who have insurance, there is a serious problem of overutilization of facilities. Okay. Now, let me give you an example from India. What is moral hazard? Well, about 10 to 12% of deliveries, babies in nature, are complicated, which means they will require cesarean section. Cesarean section is a serious surgery. It requires 3 to 4 days of hospitalization. It's much more expensive compared to natural birth. Yet, if you look at government hospitals versus private hospitals, there is a very big difference. In government hospitals, about 12 to 13% of all deliveries are cesarean section. While in private hospital, that number is as high as 36 to 38%. So 3 times as much. That should tell you what moral hazard is and what is the problem with incentives. There is a huge overutilization of facilities, right? Because again, in insurance market, neither the patient who is covered nor the doctor who's actually going to provide the care have the incentive to lower the cost, right? This is a very standard, it's very well researched and articulated, and these incentive problems are at the heart of market breakdown. So insurance market, remember, is it's an important financing tool, but it comes with its own perils. So we have to use technology in order to lower these problems, in order to improve these problems. That's why Ayushman Bharat is bottom 40%. Everybody has to be covered, right? It's not saying only sick people and so on and so forth. Now, in India, publicly financed health insurance scheme, Ayushman Bharat is for the bottom 40%. But you have CGHS, you have ESIS, you have all kinds of publicly financed or government financed health insurance schemes that exist for other quintiles or other classes of people. States have had publicly financed health insurance schemes for now 20 years. You have had the Vajpayee scheme in Karnataka, the Kalagnar scheme in Tamil Nadu, Arogya Shri in Andhra Pradesh. So states have been experimenting with this. In 20 years, now we also have the technology to identify fraud. So if to those of you interested, read up how new technology solutions are being deployed to identify fraud. So this is where machine learning can help you. You can look at the data, and when you're seeing repeat offense or certain kinds of claims being filed from certain places, you know that that is a red flag. So it comes up for scrutiny and so on and so forth. So there are technology solutions to otherwise what seems like a very difficult problem, right? Now, this is something I think it's very important for all of us to appreciate. Sorry, I should have done this. Ayushman Bharat is for every state. Now, of course, I think Bengal might have still not signed on to it. Odisha, I think, eventually did. Delhi, I think, has also. But barring the federal politics apart, talking of the economics, India doesn't have a very unified health market. In fact, different states have different degree of dependence on public health. In fact, if you look at the earlier NFHS data, you will see that in places like Odisha, Kerala, Jammu Kashmir, Tamil Nadu, Himachal, more than 85% of the poor people are going to government hospitals for care, right? And this is not just poor. In fact, this kind of number is seen for the top quintiles as well. Whereas in places like UP, Bihar, Jharkhand, Punjab, Telangana, most people depend on private care. Now remember, Punjab and Telangana particularly in Punjab, Haryana, these are rich states. They are clubbed together with Bihar, Uttar Pradesh, etc., which are poorer states. So the rich and the poor depend on private care. So it is telling you that in states where government health infrastructure is not good, people depend on private health care. Okay, where the government district hospitals are good, the primary health centers are good, people across income groups, the rich and the poor, are all going to government hospitals given a choice. All right, now, why is this categorization? Why is this fact important? Because Ayushman Bharat is government financed. In the government hospitals, there is no incentive to overuse facilities and raise the cost, because doctors are not going to get paid more if they do an additional surgery. That's the government system, it's fixed. While in private, financial bottom lines are there. That is just the nature, that is the incentive. This is what we mean by markets breaking down in health. The incentives in healthcare are such that cost escalation will happen in places where people depend on private healthcare. So how are we going to finance Ayushman Bharat after 20 years? If we see the country moving in very different directions, that in states where government infrastructure is good, government hospitals are good, primary health centers run well, Ayushman Bharat will work very well. So we will be moving towards a UK/Canada kind of a system, /Thailand. These are good public health systems. At the same time, we will also have states like UP, Bihar, Jharkhand, Punjab, Telangana, etc., which are going the US way. But the US spends 18% of GDP on healthcare. Are we ready to bear these kind of expenses for healthcare? Right? We are currently spending less than 2%. So it's not even about just going on spending more and more. It's about fundamental economics. The incentives are going to be such that we will have to end up spending more and more and more. So the lesson here is Ayushman Bharat is a very important step towards universal health coverage. But are there lessons from Singapore as well? Can we learn from countries which are spending much less and have better health outcomes? Again, technology is an enabler there. All right. We are in a position to lower costs if we have better data. Now, how do health insurance firms typically cut down costs? And by the way, we have been experimenting with health insurance for many years, even before RSBY, because the whole area of microfinance, which are economically active, but they are poor households, the microfinance type of clients. Their experiments with health insurance was done long time back, 20, 30 years back. Seva Bank. So there are many smaller institutions which did, and there are lessons from those which we can bring to the large programs like Ayushman, etc. That either limited coverage or you only depend on public hospital because the costs can be controlled. Diseases, that's why you'll have many diseases which are outside the insurance coverage because, it just becomes that much more expensive and problematic. Now, there is a fundamental coordination failure problem that we want insurance to be cost effective, so the cost should be less. But how do you reduce cost without attaining scale? So it is a coordination problem. that you want people to buy, you want huge amounts of coverage, but simultaneously you also want the quality to improve. You can't wait for coverage to increase before you start working on quality. People will not come. All right. We have seen this in microfinance also, that people might have the coverage, but they're not filing claim, especially if somebody else is paying your premium. If you pay premium from your pocket, you know what your coverage is. But when the government is paying, then you don't even know what they're paying for. So people, that is, of course, some amount is incentive, but there's also financial literacy. People don't understand a lot of these things. Again, technology becomes an important way to improve access. All right. Now, here is a very interesting graph where I think it's important to appreciate that government is a large player in health sector and is likely to be. It's a public good in many ways. But look at the relationship between economic growth, so GDP per capita on the x-axis, and decline in infant mortality rate on the y-axis. This is over the period of 20 years. Every state of the country, big states, small states, poor states, rich states, northern states, southern states, every state which has grown economically has also lowered its infant mortality. So it's important to know that, growth leads to many positive things by itself. When there is more food to eat, there is clean water, there is healthcare facility available, which is all measures of economic growth, health outcomes will improve on its own. All right. This is a very important message to take away, that economic growth leads to improvement in healthcare on its own as well. So economic growth is also a great enabler for improvement in health. Look at the relationship again, though. It's not uniform for different states. So if you look at neonatal mortality is an important metric, guys, because it tells you how many babies have died in the first 21 days of birth. It's really a good proxy for what is the quality of public infrastructure, because babies under 21, when they die, clearly the hospital system is, or basic diet, or malnutrition is a huge problem, infection, etc. is a big problem. Okay. Now there's a current task force running in Madhya Pradesh, and I'm chairing it, which is addressing this specific problem. That a state which is otherwise growing, but neonatal mortality is one of those very rigid, and technology again becomes a big part of our solutions, because we have a surveillance system. We're trying to identify highly vulnerable pregnancies and trying to monitor the mother so that we can prevent neonatal deaths. But look at the states here. Tamil Nadu and Gujarat are the only two states that have done economically very well and also improved neonatal mortality. Otherwise, of course, if you look at the average, the correlation is positive, that with economic growth, again, neonatal deaths are falling. But few states are standing out as superstar states, right? Breakout states that have achieved economic growth and development. Many states are still struggling, right? It's a very large country. I don't need to say that to you. We are growing at very different rates. So even when we talk of technology deployment, look at Punjab, look at Haryana and Punjab. Punjab was richer than Haryana 20 years back. Today, an average Haryanvi is 1.5 times richer than an average Punjabi. All right. It tells you what are the local, first of all, resources available for some of these transitions we are talking about. All right. Look at Gujarat again. Look at Tamil Nadu. These are states that have grown much faster than all India average. Now, an important aspect in all of this is, we are right now still talking top down, that we can do this from Delhi, Raipur, Lucknow, Trivandrum, so on and so forth. A lot of it is bottom up. Financial literacy, especially when you think of insurance, you'll be surprised when you go on the ground. People don't understand the concept of insurance. People understand savings. So deposits are something they understand. And that's why when scams like Sharada happen, a big problem is financial literacy. People are told, we will triple your returns, give us deposits. So you must appreciate why giving bank license is such an important, it's a difficult, it doesn't happen easily, because banks are so well and over regulated because they are holding deposits of poor people. So they have to be very well regulated. People still understand deposits. Those scams happen. So literacy is important. But when it comes to insurance, that basic understanding is not there, that if I'm depositing, if I'm basically paying a premium, what is the actual gain? So when it is about selling insurance, or mandating insurance like Ayushman Bharat, it must simultaneously be rolled out and implemented along with financial literacy classes. Who will do that class becomes an important question. Should the government do it? Are these Doordarshan programs in the evening that nobody will watch? Should it be part of school curriculum? Should children be taught? Now, these are all open questions, and we have to come up with ways in which we start to make basic financial sort of information and knowledge a part of day-to-day running of households. We have to make it. Otherwise, a lot of small retailers, small households are losing money in a lot of this market. So we want to promote insurance, we want to promote leasing, we want to promote pensions, but financial instruments are not always easy for people to understand. Okay, so literacy becomes a very important part of this. Now, the biggest takeaway from all of this, now that you appreciate that technology is not a silver bullet, we can't just implement from the top and the magic will be done. No, the bottom, the last mile, so-called actual entering of data, getting that digital transaction recorded is difficult. We don't have that capacity everywhere. Let me also give you another piece of statistic. What is the leading cause of death in India? Today, you're hearing so much about COVID and everybody's so excited. But if you look at the data, the leading cause of death is fever. Now, fever could mean many things. The second leading cause is unknown. We don't know. That's because the way the data is entered, either your doctor is going to take care of the patient or that doctor is going to enter the data. Also, entering data is not simple Excel forms, guys. These are ICD-10. These are classifications of diseases, international classification. So there are codes how you can enter data. Now, given the shortage of doctors and shortage of nurses, data entry is the last priority for a doctor, rightfully so. Okay, so leading cause of death becomes unknown and fever. Fever could mean many things. So what is the quality of the data and how are you going to use that data? Okay, so appreciate the fact that technology solutions exist. The biggest improvement I think that we will have using blockchain, which we are already beginning to see, is defragmenting the market. A person goes to a village, shows, to the primary health center. The guy says, get an X-ray. He will do an X-ray. If nothing happens, so he'll go to Patna, PMCH. He will get, that guy will say, again, get an X-ray. In 15 days, again, he'll get an X-ray. Nothing happens. He's finally sent to AIIMS. He'll take the X-ray for the third time. Fragmented markets lead to huge diseconomies in scale, okay, and huge losses of wealth to poor households. One of the leading causes of poverty is healthcare. 7% Indians fall below poverty line because of healthcare expenses. And these are under normal circumstances, okay? So during COVID, we had to estimate what has happened. So appreciate that using blockchain and digitizing all of it means defragmenting the market. So that one X-ray which you have taken 2 months back, unless something again has happened, it is valid, right? The health records can now be maintained. Then it is portable. Earlier, it was not portable. You couldn't take it from one end to another. Of course, all of this is within the architecture of consent. Who should have access? You have the access as patients, etc., etc. But blockchain makes it possible to make the whole system far more efficient. Similarly, in the insurance business, it is being used to come up with better recording. Because remember, if you have better recording of history of use, etc., you can come up with better premiums. Right? There are ways in order to also identify fraud, etc. that happen. India is already well on its way. The health stack, what is the health information exchange? Health stack in India is now already developing every day. More and more data is getting put on it. CoWIN, which is the one most popular and what you're familiar with, is the latest. But a lot of data is getting defragmented and sort of unified and put on this exchange. Now, the impact is not just in terms of unified health record, etc. You can imagine what wealth of information exists for coming up with AI, artificial intelligence and machine learning, etc. solutions. These are not abstract words, guys. In fact, just yesterday, there was an excellent PhD dissertation at All India Institute of Medical Sciences, where a neonatologist has come up with the pediatric department, neonatologist. She's a very bright doctor. She's come up with machine learning solutions based on historical data of sepsis of babies. So imagine now, it is helping this past data can help the doctor make real-time quick decisions. So you see more patients, you see, patients, and better, because you are overcoming a lot of human judgment. There are errors in human judgment, etc. So AI ML rests on the quality of the data. It's not just blockchain making things more efficient and cheaper today. There are future solutions that can be used, right? Similarly, you want to go beyond insurance. That the whole example of Singapore was given to tell you that we don't have to necessarily only rely on insurance, because insurance can very well give you that 36, 38% C-section situation. It is giving us already overutilization, like the US. We need to also experiment with products, new financial instruments for healthcare, and health savings is a very promising one. That people save for healthcare, so we have to design in such a way that people are able to save better and save more, just like in Singapore. So you don't have overutilization of facilities, so the cost escalation doesn't happen. That's why they spend 4%. Okay, so I want to end with that. Of course, I'm very happy to take questions, and if something particularly excites you, we can talk more. All right. Thank you very much.
Thank you, ma'am. We are glad to have a better understanding of the technology, that how it can be used to tackle problems in the field of healthcare. We extend our sincere sense of gratitude to Professor Shamika Ravi for being so kind to us and explaining us the importance of financial literacy, financial methods of the healthcare, insurance, and terms such as moral hazard, and information regarding different schemes prevailing in different states of India. I'm sure that apart from having a deeper insight into pandemic, public health, and technology, our audience would also be extremely eager to put up relevant questions and interact with ma'am. So all the attendees are requested to put their queries in the Q&A box.
I guess we have a question. If ma'am agrees, can we start? Okay, ma'am. So the first question is, how can we, as primary adopters of such technologies with appropriate understanding and education, implement these small changes on our end?
I think for your generation, you're already early adopters. In fact, I'm doing this seminar, this talk from Bangalore, and I'm absolutely blown away by the nature of entrepreneurial capabilities that exist. They're already, adopting, because the fear of failure is much lesser than perhaps my generation had, and definitely my teachers and so on and so forth. So, look, if you have a business solution, or you're trying to integrate this technology into some aspect of your life, the chances are somebody has already done it before. So you are likely to find, cases that exist. Specifically, if it comes to health sector, education sector. Education, what you have seen in the pandemic, the sector that has perhaps done very well from a business perspective is the ed tech space. Adoption of technology in the ed tech space has grown by leaps and bounds. You have leading unicorns come out from it. At the same time, of course, my concern as a public policy researcher is also, of course, now we are saying 80% of Indians don't have access to smartphones on a regular basis. Households that have a smartphone have to split it between children. So work from home might work for you and me. It doesn't work for a very large number of people. And so the education, the school system has been one of the biggest sufferers in this pandemic, because technology adoption is not that simple. You are limited. You're limited by access to. And also, by the way, there is research which is showing that there is serious loss of learning. Children under the 6th grade, so 1st to 6th, are showing serious cognitive sort of deterioration. Mathematics skill, writing skill, reading skill, they're all falling. So the future, we have not yet measured the true cost of this pandemic, and education is going to be a very big cost. Yeah.
Thanks for answering that question, ma'am. Next question that we have is, what is the major reason of health infrastructure in states like Bihar and UP, and what can we do to improve the situation there?
Well, a lot of people say financing is a key gap, meaning we should spend more on health. Yes, we should spend more on health. In general, we should spend much more on health. But when you think of problems of states like UP, Bihar, Jharkhand, medicines, they have doctors, quality is a secondary issue, but there is more food, there is more water. So growth is leading to improvement. But in health and education, markets break down, which means it cannot be left alone to markets to provide solution. Government has a role. And by government, I mean at the highly localized level. If I fall sick, can I go and get quality care in my primary health center? The answer is no. While a citizen in Goa or Tamil Nadu, the answer is a resounding yes. Now, can you imagine what state? It's not just financing, state capacity. State capacity means, can the state deliver? Again, the reason technology is so promising and today people are so bullish and optimistic on technology is because technology, the whole, again, one way to understand blockchain is it cuts out the middlemen, the intermediaries. Intermediaries are very costly. So defragmenting the market, that's why a lot of states are finding this adoption, very promising. Now we still have to see how the adoption happens, but at least there are excellent experiments that are underway.
I hope that answers the question. Thank you so much, ma'am. The next question is, what are some of the challenges that countries like India face in adopting blockchain technologies?
I think the biggest is access to that technology. Access is a big problem, particularly when you go beyond large urban centers. Okay, when we are talking about state, remember, governments do have resources. If government makes it a priority, it gets the resources. But to deploy it at the local level it's still a very tricky business, right? So. For instance, if I get some care, and again, all the examples we are talking about healthcare, but you have to apply it to many other. It could be in agriculture. It could be just financing. That how do I link my local cooperative bank to, let's say, the district or the a larger bank, and so on and so forth. It's the mechanism is the analogy is similar. That's why I'm sticking to health. But the fact that at the local level, while digitization is happening very fast, access to that technology, and I think there is some degree of distrust when it comes to financial products, that making it available for everyone to see, when it comes to health records, etc. I think literacy is also a very big problem. People don't quite understand. I think one of the biggest impediments is literacy, is basic digital literacy. Right, and yet, if younger generation, the person might be a school dropout and hasn't studied beyond 5th grade, but he knows exactly how to use YouTube. He knows what to type. He knows how to watch, get entertained. Data is practically free. So you see, adoption of technology is happening, but there is an age-wise discrimination. There is a gender-wise discrimination. Access to digital technology remains a concern.
Okay, ma'am. As you just mentioned that literacy is a major problem and some of the scams were the major reasons that they took place. How should we as individuals should focus upon it, and why is the government not focusing or not taking appropriate steps to improve it?
Steps have been taken, except they are not at a level where these are like drops in the ocean right now. So RBI ran financial literacy lessons under Usha Thorat 20 years back. So sometimes I feel very old because we are reinventing the wheel, but that is the nature of this is a continent of a country. And you simultaneously have a Bangalore city, and then you have Dimapur, or you have Kannauj, and these are such extremes that coexist. It's anachronistic because technologically and there are generations apart right now. So I think it is being done, but not at it is still a lip service. We need to make financial literacy part of school curriculum. We need to make it part of neighborhood, the self-help group kind of. If those mechanisms exist, we must start promoting, by self-help group or ROSCAs. What are ROSCAs? Rotating Savings Credit Association, which is a very fancy, nice word for what are kitty parties for women that run in every village, run in every little town. Women gather up, they save a little amount of money, somebody gets the pot to buy a durable good. Okay, it's the oldest system in the world. It exists in every country in the world. These mechanisms are indigenous institutions that exist. Financial literacy has to be transplanted on top of some of this. Let's make the modules easy for people to understand in local language. Compounding ka kya, what is the strength of compound interest rate? What does it mean to save little amounts? Why is Sharda, why they call it Sharda chit, but do you all know that it is not a chit fund? Because India is one of the few countries in the world which actually has a chit fund act. Chit funds are Roscas. Sharda was a Ponzi scheme. They're very different, right? So financial literacy, I think, sometimes I have to do that even for my MBA students, because the media is not the most educated either. But we have to come up with simple modules and we have to educate right from the school how to manage finances. Yeah.
That would be a great answer, ma'am. The next question that we have.
Tanishta, Abhishek sir would like to ask one question.
Sure,
Sir,
sir.
you can.
Yeah, good evening, everyone. Thank you so much, Professor Ravi. It's fascinating to hear you. And let me tell you, I wait for your data facts every day on Twitter. And it's almost every day that, you share something which is encouraging and something which is at the end of the day, we have to, keep on reconciling with our previous day's data. I myself belong to insurance background, and I have a very, very specific question. We keep hearing, and we are doing that for years now, that insurance penetration in India is very low, especially if we talk about non-life insurance. Do you think that after the introduction of Ayushman Bharat, we need to course correct the numbers, or do you think this would not be the correct way of correcting the penetration level? Because once the, people now have that cover of 5 lakh rupees. So you think that needs to be covered in that penetration level?
Definitely. I think when people say penetration, they are not talking necessarily of the government coverage. Because, it is not seen the way traditionally the industry sees insurance. And yet, I think, when you said non-life, we have to see why is it that very otherwise successful pilots like property insurance, livestock insurance, very successful products like weather insurance, rainfall insurance. These are a little more sophisticated. They are more derivatives, but the take-up is very low. Right now, we are saying that in a country with so much uncertainty, we are still weather dependent. The rainfall has a very large role to play in our economy, not just agriculture, many other parts. Why is it that insurance is not doing well? In fact, when we ran surveys almost 20 years back, and we asked people, what is one of the reasons you want to save? They said health. We want to save because health expenditure bahut jaldi ho jata hai, bahut bada ho jata hai. We want to be prepared. So health is one of the biggest reasons we want to save. Then in a simultaneously survey, which was based for designing savings instruments, we asked, what is the one big reason why you're not able to meet your target for saving? Like every month, I want to save 5,000 rupees. Why are you not able to meet that target? And the answer was again, health. कोई ना कोई बीमार पड़ जाता है. If आप घर में नहीं है, तो somebody in the neighborhood, somebody will come and take the money. Then the child has a runny nose, फिर antibiotics, something. Now that just tells you that, why we need more and more of health insurance. So Ayushman Bharat is there, Abhishek. But remember, Ayushman has 40% of the population, right? And CGHS and ESIs and all exist. So obviously that number must be revised, many are. But if we are going to have publicly financed health insurance scheme, we have to take it beyond the bottom 40% also, simply to make insurance more viable in the long run. Otherwise, we are going to be stuck with all kinds of cost escalations. The fragmented nature of government health insurance itself has huge diseconomies of scale, right? That is number one. Number two, I think literacy is a problem. And this is where now you are seeing, this started about 10 years back, that our savings are not always in the most productive manner. And more the uncertainty, the more people hold on to assets like gold or real estate or something like that, because wo to hai apne haath mein. Financial, products people don't understand. So when we are trying to bring more and more household savings into the financial markets, I think we'll have to educate people more. We will also have to give them good products. I think we have completely undermined the role for product design. Abhi bhi dekho, such plain vanilla products are getting sold in an otherwise very sophisticated markets. So why, we have to experiment with new product designs, which people find valuable, and we need to educate, and people will buy. I mean, after all, you're seeing the kind of bull run in one part of the market. So why is it that in the larger market, people's understanding and faith, I think, in financial market is so limited? I think there is a role for policy there, but there's also a role for industry in the form of product design. Sorry, that was a very long answer.
I hope that answers Abhishek sir question. So would you like to ask any other?
No, thanks. And thank you so much, ma'am. Thank you.
Thanks, ma'am, for answering that question. The next question that we have is based on blockchain in healthcare. So we wish to know that to maintain a proper blockchain system, especially when it comes to healthcare sector, we need a huge manpower. So does it mean that it will lead to increase in employment, or does the implementation of technology would lead to increase in unemployment?
Sunishta, that's an excellent question. Technology very seldom in emerging markets like ours have replaced labor. Technology is mostly complementary. So it helps you reduce cost. It helps you do things a little faster. It helps you, that last mile connectivity and so on. But we have not reached the stage of automation where we are actively deploying capital intensive, technology to replace labor. Some of it has happened in the apparel sector in the last 30, 40 years, that we have our labor laws were so difficult to maneuver that people said, kahan labor union and how, forget labor. We will much rather go for power looms, etc. Right? Now, those are the bigger policy questions, that we have a large labor force. What should the policy intervention be that people can get jobs out of it? And our current, I would say, people, economists, and mostly we are to blame. We talk about growth as some abstract concept. We want to attain growth. That is like saying, ye outcome lana hai. The levers are all through jobs, through wealth creation, through actual, setting up of new business. So those micro foundations are very important. So jobs should be our number one priority. Technology is not as much of a hindrance as it is made out to be. In fact, in the Indian case, technology is more of an enabler, because almost the entire IT sector, almost entire pharma sector, all our big engines of growth today are on the back of skilled manpower complemented with technology. And that is the future. So which means we also need a large labor force trained and skilled in these things.
Thank you, ma'am. The next question is based again on healthcare. So blockchain, as you told, is a relatively newer technology. So how can we reduce hesitation among official and government departments to improve overall technological literacy? As you also mentioned in the speech that that healthcare workers would often focus upon the surgeries and they would not focus upon creating Excels and maintaining data. So how can they focus, and how can they how can we as individuals, or maybe the government, can work on to remove the hesitation among them?
I think that you see the trial has already started in terms of many departments of the government, perhaps not entirely on their own, but they are being forced to adopt blockchain. Okay, they are being, because it leads to greater transparency and fewer leakages. Now, simultaneously, as smart students, you must know that people live in society, not in economy. So power matters. At the end of the day, we can't pretend that economics is beyond, outside of the society. Power struggle, and the political economy of it is very, very important. So in many cases, in the industry, there is a natural incentive to use blockchain because it helps you attain economies of scale and efficiency, lowest cost, etc., etc. In the government, the incentive is not very clear. In fact, it can be, I like to keep things a little more confusing because that maintains my status and sort of, right. But these are all short-term glitches. I think the overwhelming power of the blockchain technology is here to stay. Department after department, government after government, across different levels are being forced to adopt this.
I guess that was all for the questions, ma'am. Thank you so much for being here. It was extremely kind of you to take out valuable time from your busy schedule to not only explain the role of blockchain technologies in various domains, but also for resolving our queries regarding this very important topic. Thank you so much, ma'am. And it's an honor for us to host you today.
Thank you so much. Thank you all for this wonderful opportunity.
On behalf of the Center for Multidisciplinary Research, Innovation and Entrepreneurship, Shahid Rajguru College, I am humbled to take this opportunity to present our token of gratitude to Professor Shamika Ravi for gracing this session and enlightening the audience on the use of blockchain technologies in building health, insurance, and financial change to meet the challenge of COVID-19 pandemic. The painting in the background has been made by Urvashi, a student of BMS second year.
Wonderful. Wonderful. Thank you. Thank you very much. Take care, all of you.
Ma'am, we would just request you to stay back for a few more seconds for a group photograph.
I request to stop the presentation.
Request all the panelists to turn on their videos for a group photograph.
You can stop presenting.
It's done.
Thank you, ma'am.
Take care. Bye-bye.
Thank you so much, ma'am.
Before we conclude, we would like to thank Principal Ma'am for being a catalyst and supporting us always. We would like to thank Ma'am for inspiring us and being our pillar of power. We would also like to express our gratitude to Mr. Abhishek Tandon for gracing his presence. Along with that, our knowledge partner ICSSR for supporting us to conduct this insightful session. Ranjana ma'am for being a supporting body, for supporting us and providing this golden opportunity to host this session. We also extend our gratitude to all the professors, research scholars, and the fellow students for showing their keen interest. Last but not the least, thank you so much, teachers, for always providing us with various opportunities to organize such informative webinars. Thank you so much for joining in. Have a great day. And
thank you so much.
Thank you to all the organizing team and council.
Thank you.
Thank you. Thank you so much, everyone.